Okay, so far we've been talking about survival analysis in general, in the sense of for any longitudinal study where we are following people over time and we are studying the time to an event. And so our variable of interest is time to some event. And that event can be a clinical event that is good, a clinical event that is bad, but you are actually analyzing the time distributions. Right? That's why we're interested in the survival time. We're interested in the hazard function, which is a function of time. But out of convenience, in only having to report one particular hazard ratio when we're comparing two groups, we rely on the proportional hazard assumption as a way to then be easy in how we report the results. We just report only one. So as I mentioned earlier, if you feel uncomfortable when looking at the data, looking at the tests of the assumption, that you don't feel that you trust this proportionality assumption in your data, there are other ways to present the data, not just have one. And so that's what we've been talking about before. Now we're sort of going to move on to if I'm doing survival analysis in a clinical trial. So if you're doing it in an observational study, retrospective, everything we've talked about works, but there are other requirements that happen when we are in a randomized controlled trial. And we're sort of talking a little bit about what we are expected to do for it. But in some sense, if you look at clinical trials reported in the literature, the analysis or the survival analysis that they do follows very closely a template. They don't deviate much. They don't do any fancy stuff. They don't do accelerated failure times. They don't do a lot of more complex things. Maybe they should, because they would be better fitting the data, better fitting the nuances in their study, but they seem to always follow a template. When we're talking about the template of what is a standard application of survival analysis to a clinical trial. So I'm assuming all of you have knowledge and experience, or at least knowledge of what a clinical trial is, what it's trying to do. And if not, let me know so we can briefly talk about it. But I'm assuming that you know what a clinical trial objective is. And so what we're now going to be talking about is how do I go about using survival analysis in clinical trials. So we'll be talking about the main thing is in a clinical trial, you have to choose an outcome as the variable that is going to be variable. Yeah, maybe I touched something. The variable that you're going to use to judge whether the intervention works or not. So when we're designing a clinical trial, the investigator will say, oh, I want to test the efficacy of this intervention. Maybe I should use the other one. So when we're designing a clinical trial, usually the clinician comes to the statistician and says, I want to design a trial to show that this intervention works better than this other one. So then my first question to them is, how do you judge whether it works? Based on what? And they'll say, oh yeah, I want to prevent fewer cardiovascular problems. What cardiovascular problems? And I force them to define an outcome. And they will say, no, I want to prevent heart disease. I want to hospitalization for heart failure. I want to prevent strokes. I want to prevent angina. I want to prevent this, this, and that. Okay, which one is your primary one? Oh, no, all of these are important. Okay, fine. All of them is one more important than another. If they can tell me if one is more important than another, that becomes their primary. Maybe. Now we have to go about defining that's your clinical event, heart attack, let's say, or death from cardiovascular reasons. And I say, okay, what are you interested in about that clinical endpoint? Are you interested in its occurrence, yes or no, in a given 2-year period or 6-month period or 5-year period? Or are you interested in delaying it to occur? You want it to not occur quickly. Are you interested in the time to the occurrence of that clinical endpoint? So I make a distinction between a clinical endpoint or event and your random variable that you're going to use. Is it a binary variable or is it a time to event variable? If it's a time to event variable, then survival comes in. But if in my discussions with them, it turns out that they're looking at the number of some particular counts of cells, then that's not a time to event. If they're looking at, oh, I want to look at change in weight, that's not a time to event. You have to have a time to event. Oh, I want to look at cognition over time. Well, that's cognition over time. That's not time to an event. An event would be when my cognition goes below a threshold, that's an event. Or when my BMI goes above a threshold, that's an event. Or when my EGFR goes below such and such that I require dialysis, then that's an event, right? So you have to make a distinction between talking in generalities, talking about a clinical event or a clinical observation or a clinical measurement, and the random variable that you're going to use to design the study. Because we'll design the study to test the effectiveness of that outcome variable with sufficient power. I'm assuming all of you have had, level of significance, type 1 error, type 2 error, and power, sample size, all of this you've had in other previous courses on statistics. We're not going to go into that. But usually all clinical trials are powered for the primary outcome variable, not for anything else. And that's very important. Everything else that you measure, all of those secondary things that you measure are very important clinically and to the patient and so forth, but they are not powered to do that. So you're not powering for that. You're not necessarily testing for that. You can look at them for consistency. You can look at them for hypothesis generating. You can look at it for deeper understanding of the processes, but they are not tested. So I'm going to be talking about testing in that. And so now the specific application is going to be survival analysis in a clinical trial when I'm testing that outcome. And the outcome is the most important thing that you determine at the beginning of a clinical trial. So you cannot change it in the middle and say, oh, it's not working for this. I want to study this other thing now. You're not allowed to do that. Or this one is looking better this way, so I'm going to change it to that. You can't do that either. So there's all of these requirements on the clinical trial. That's why to keep you from cheating, that's why you have to register your protocol and register your statistical analysis plan before you start the trial, or at least before you look at the data, you need to do it. So we'll talk about the application of survival analysis in clinical trials when we have the case of a single primary outcome, which I've been talking about. But many times we have multiple outcomes that are equally important. So we call them multiple primary. How do we deal with multiple primary? Then we will have competing risks. We're looking at time to dialysis, but some people die before. I'm looking at time to get in a heart attack, but some people die of cancer before or die of other things before. So there are competing risks, and we'll talk about what to do with competing risks. And then the more interesting and complex situation when we have repeated occurrences of the outcome. So now I'm interested in heart attacks, time to the first heart attack, or time to the first and the second, time between the first and the second, time between the first, the second, and the third, time between the first, but oh, wait a second, if stroke changed that risk, what do I do now? Because they had an intervening risk, or they had a bypass surgery, or they did this. Do I take into account those things as outcomes? Do they affect anything? And these are the complications. So what we've had so far in the morning is the simple survival analysis, time to an event. The first part of the clinical trial is also simple, time to the first occurrence of your clinical endpoint. Plus, that's it. But most people are not satisfied with just one outcome. They want to look at a bunch of other things. If you want to look at a bunch of other things, you need to deal with the multiple testing and the multiple testing of not independent stuff. These are correlated things. All these other outcomes are related to each other. So forget Bonferroni. Those things don't work here for multiple testing. You have to adjust it in different ways. So we'll be talking about how we do that. All right. All right, so choosing the primary outcome variable in a randomized controlled trial. How do you choose it? First of all, this is going to be the one and only variable that you're going to use to judge whether it works or not. So you better choose it wisely. Right? So how do you choose it? They give you a bunch of criteria that people use in choosing it. This is not the statistician choosing it for you. This is you choosing it for yourself. So you have to figure out, what are the clinical criteria? Is it meaningful? Is it relevant? Is it important to whom? To patients, to funders, to healthcare providers. Something that is going to be modified by your intervention. If your intervention doesn't modify it, then you're not going to have an impact. It better be something that can be modified in a reasonable time period. What is the funding period usually? Meaningful changes in the outcome variable are seen as important evidence to warrant changes in clinical practice. You know what will change practice in your field. The statistician doesn't know that. So don't ask the statistician for choosing your primary outcome. But then there are practical criteria. It should be observable and measurable with some sort of accuracy, precision, and objectivity. It should be unambiguously defined. You're going to say, oh, no, we're going to look at whether they're hospitalized. Who decides hospitalization? I mean, it sounds like it's very objective, hospitalized, but the patient has to decide they want to go. The physician may have to decide also, no, you don't merit hospitalization, or you do merit hospitalization. Or the hospital can decide, oh, we don't have enough beds, so we're not going to hospitalize it, for example. So then that outcome is not happening because of other reasons. So it's not really a good outcome. What is the best outcome? Death, any cause, because that is certain that it occurred. But it may not be relevant to what you do. So you have to choose something that is relevant. Also something that's not too costly to determine. And if it's, we call it an event-driven RCT, so that it's the sample size and power is based on the number of events that you get, then you better have a high event rate. If the event rate is very low, you have to go 20 years before you have enough. study is not feasible if that's the outcome. So people choose different outcomes to reduce the sample size, study duration, or increase power. You should not necessarily choose it based on statistical considerations. Sometimes that's, we've had physicians who will come to us and say, which one gives me more power? I'll choose that as a primary. Ridiculous. That should not be the way to decide. It should be on a clinical criteria. So enough on that. I assume you choose the primary outcome. And then we have, depending on the type of the primary outcome, we will have the analysis. It's like every statistical analysis depends on the random variables distribution. If it's a continuous one, we'll just be comparing the means at a given time point between intervention and control, simple t-test. If it's binary, we'll compare proportions at a given time point between intervention and control. We would calculate the relative risk or do Fisher's exact test. Nobody uses odds ratios in prospective studies. It's always relative risk or hazard ratio. If it's a time to event variable, which is the topic of this workshop, then we are comparing survival curves or hazards at a given time point, or most likely it's compared over time. This is what's more typically done. And it's the hazard rate ratio that we calculate and the Cox model. So we've seen this. This is exactly what we've done all morning, but nothing new. So the analysis, the application of survival analysis in clinical trials is simple. It's the log rank test, calculation of a hazard rate ratio, and doing the Cox model to explore covariance. That's it. Finished workshop. So that is the easy thing, and that's the template. This is what most trials do. They don't deviate from this. But typically, we have not only the primary effectiveness outcome, we have several secondary effectiveness outcomes. I'm interested in this, and that. Why are you interested? Because they're clinically important, and you want to judge them as well. So how do we deal with it? So here are some examples. In cardiovascular research, we may be interested in cardiovascular death, or we may be interested in cardiovascular clinical events like MI, myocardial infarction, stroke, heart failure, hospitalization, sometimes put together with cardiovascular death. Somebody came up with an acronym for that combination called MACE. They call it MACE. But we also may be interested in some biomarkers like NT-proBNP, or troponin, or lipoproteins. We may be interested, and some people work with the aging, they're looking at functionality. They don't care whether they had a heart attack or not, but they're still able to tie their shoes. They're still able to go to the washroom, bathe themselves, dress themselves, how strong they are. Can they walk 6 meters without, or for 10 minutes, how far they can go? Or sometimes patient-centered outcomes. Like, I don't care if I've had this or that, as long as I can, go on with my activities of daily living. If I can play with my grandkid, if I can do this, that's what quality of life. I can take a walk in the park. So you can have all sorts of outcomes. Some of them, you need to think about what is it to whoever is the stakeholder of your clinical trial. And so you have multiple things. You have multiple choices. We can choose only one as the primary one, and then we're fine. No problem. We can choose or co-primary. And I'll talk about the difference between multiple primary and co-primary. It's semantics, but the US FDA is problematic about semantics, and they make a big deal about it. We'll talk about it in a second. Or you could create a composite endpoint. Composite endpoint is putting things together. And the traditional composite is the composite occurs if any of its component occurs. There's a relatively new one called the win ratio. I don't know if you've heard about it. That is a summary of wins and losses of components in some hierarchical order. So there's different ways of constructing composites. Everything has an advantage, everything has a disadvantage. Okay? So if I choose only one or choose two or more as coprimary or create a composite, I've created clinical events. The event may be only one, event may be two different events, or I have one composite event. So I have events. And if I have events, what is my analysis? I can either do binary, the occurrence of the endpoint in a given time period, or the topic of this course, I can do time to event variable, time to the first occurrence of the endpoint, what we've been doing so far. So I can have time to the occurrence of the single one that I have, or time to the occurrence to one, or the second, or the third. Then I have to deal with handling the alpha level, but I can do that. Or if I have a composite, like the traditional composite, it's a clinical event, time to the first occurrence of any of its components. And that's simple analysis of what we've done so far. So in all of the situations, we have the time to event variable that we've always been talking about all day today. Nothing different. The win ratio is slightly different. It is something happened. So the win ratio composite is a different variable. It is not a binary variable. It is not a time to event variable. It is a continuous variable. It has a range of possible values that are positive from 0 to infinity. And so you can calculate a statistic that's called the win ratio, but it's not a relative risk. It's not a hazard ratio. People try to interpret it similarly because it's a ratio of two things, but it is not, does not have the mathematical properties of a relative risk or the mathematical properties of a hazard rate ratio. It's a different one. Now, what are the advantages and disadvantages of doing multiple primaries versus co-primary? According to the US FDA, a co-primary is different than multiple primaries. So I have two that I consider primaries. Let's say heart attack and strokes. If I call them multiple primaries or heart attack and strokes, then one of them may be statistically significant, and the other one may not be, but maybe one of them is enough to show support for clinical efficacy, and it may change practice. But if I say the same heart attack and stroke are not multiple, they're co-primary, then means that I have to demonstrate that both of them are significant in order to establish benefit. So they force you to have both of them. So many people don't see the distinction that the FDA wants you to see. So I have to talk to the investigator and say, are you really sure you want to call them co-primary? Well, yeah, they're equally important. But if you show it on one and not the other, oh yeah, that's equally important. Then they're multiple. In both cases, here adjustment for type 1 error is required because you are splitting the alpha between the two multiple primaries. And it's hard to interpret if it occurs in different directions. It works for stroke, but it doesn't work for heart attacks. Now you have to come up with some creative clinical argument as to why that's happening and why do you think practice should change. Here, you may have to adjust for type 2 error because you may have reduced power by doing this co-primary ones. But so this is But the analysis of survival methods, they don't change. So you do the survival analysis, now you just do the Kaplan-Meier for each one of those primaries, or you do the counts for each one of those primaries. It's how you interpret it that changes. Yeah.
When you have endpoint, your Kaplan-Meier curve, there's endpoint on it. So in this, if you have two primaries, so you have to demonstrate that both of them have come to their endpoint. So then if you have two co-primaries, does it have to be like both have to be positive and then your endpoint is reached? Or is it a mean? Or what's that? What's the time interval then? What's the endpoint there?
So I think if I understand correctly, I think you are mixing two things together. The Kaplan-Meier curve, you do one Kaplan-Meier curve for one outcome.
Okay.
You do another Kaplan-Meier curve for the second outcome. They're not the same curve. They're not in the same curve. They're two separate curves.
So if you have two co-primaries, you have two separate curves. It's not a single curve, even though you have to have both outcomes for it to be clinically beneficial.
So but you need to clarify your wording. It's not to have two outcomes. What you're saying is
two or more
correct.
outcomes.
So if I have two primers, okay, I can call them multiple, or I can call them co-prime. So what I would do is, let's say I have intervention and control, and here I have the survival curve for primary number 1. And I do another one for intervention versus control for primary number 2. And this one goes to separate. And if I call them multiple, if this is significant and this is not significant, I'm okay because I have one of them is significant. But if I call them co-primary, I do the same analysis. But this is not significant, so I cannot say that the intervention is good. That's the only difference. Statistically, there's absolutely no difference. You have to calculate the sample size for both. You have to share the alpha, and
let's say it's not significant in the first one, you can test it, then you cannot test on the second one.
So that's the other one. So this is another issue too, that you may say that I have multiple primaries, but one is slightly more important than the other. So when I'm sharing my alpha, instead of sharing it equally at 0.025 for this one and 0.025 for the other one, I really want this one to be, so I'll give it 0.04, and this one, unless it's very significant, I will do it. So then we can share it that way. Or we can share it in a different way, saying there is an order to them. So this one is more important, and I will test this at 0.05. And if it's not significant, I don't even look at this. But if it is significant, then this 0.05 is passed on to this, and I can look at this. That's called gatekeeping. So I taste this one first, and if the gate is open, then I test this one. If the gate is closed, I don't even test it. I'm not allowed to do it. And that's what you specify in the protocol. Some people don't like that. So they have gatekeeping with a fallback mechanism. So instead of testing this one at the 0.05, they test this at the 0.04, and they say, if this is significant, then this 0.04 comes over here, and this becomes 0.05, and I can test this at 0.05. But if this is not significant, I still can test this one at 0.01. That's called gatekeeping with a fallback mechanism. I have a little cushion to fall back on. How much to divide it? That's whatever you want to do. There's people that have done simulations and all sorts of stuff. Right.
Find the actual answer.
Yeah. So what he's saying is that how much I split this splitting it by just dividing or subtracting assumes that they are independent as well. But if they're correlated, they're likely to be correlated, then you can sort of now have to do some simulations to say, well, maybe this can be at 0.04, but this can be at 0.18 or something like that after the simulations you do. And you can adjust it. A little bit more complicated. And this is because people want to have their cake and eat it too. They want to test everything, but they don't want to pay any penalty for testing everything. Okay. So this happens sometimes. More common though is the use of a composite. When you have multiple things, they use composites. And composites are what? They'll take several, hopefully related clinical endpoints that are hopefully of equal importance and hopefully of equal event rate and all related to the same effect of the intervention, and put them together. When you put them together, what happens? You have more events, and so therefore you improve statistical efficiency and precision. You have an increase in power. This is the main reason why we have, for example, MACE. MACE is heart attacks together with strokes, together sometimes with heart failure hospitalization, sometimes not, and cardiovascular death. So if any of those things occur, the event of MACE occurs. So you're going to have many more events, and therefore you have more power. And so you can then detect small effects of your intervention, you lower your cost, and you may be able to stop your study early. However, there are some disadvantages, many disadvantages. So it may be now complex and resource intensive because you have to assure yourself that somebody did get a stroke. Assure yourself that somebody did get a heart attack. If a stroke is mild, if the stroke is severe, everybody says, oh, it's easy to detect. But a person just was dizzy a little bit, didn't feel anything. Unless you're doing MRIs, you don't know the person had a stroke. So now you have the cost of finding out. How regularly are they going to check for these things? Or components may be inappropriately combined. Oh, I'm going to put in angina. Why? Because I'll get more events. But angina is not as important as other things, right? So maybe it's difficult to interpret study findings and determine which was impacted more. Did you really prevent strokes? Now you start looking at the components of a composite as a secondary analysis. You're not powered for that. And so you may not find things. You may have that the effect is often small for the most clinically important and biggest for the less important components. So it's prone to post hoc analysis. They do bias, and key data are often missing or unclear. And so what if it helps? Some of the components it helps, and some of the components it doesn't help, and it goes in the opposite direction. So there's complications on this. But from a statistical standpoint, survival analysis is just because it's time to the composite occurring. Very simple. Everything we've done on survival analysis applies to all of this. They're exactly the same. Now, because many people may not know what the win ratio is, just to mention what it is. What it is if you have many things that may be important, but you know an order for it, you calculate, you compare everybody in one arm to everybody in the other arm, and you see how many times that comparison, the intervention won, and how many times the control arm won, and you just take the ratio of wins to losses, in that sense. And if there's value is a 1, then they're equally in wins to intervention B. This was proposed in 2012 by Stuart Pocock from the UK, and it's recently been getting some traction. We didn't get it initially for a long time. In fact, Dr. Pocock came and gave a talk at our university, and he said, oh, he doesn't think too much about it, but some of his students are promoting it a lot. People think that it increases their power, and that's the reason they want to do it. But I don't think so necessarily. We did some simulations or some scenarios to show it doesn't necessarily do it. So, but it's another alternative for composites. Now, here's just an example of what true life is in the cardiovascular arena. I have two interventions, A and B. I want to compare them. I'm looking at outcomes that are cardiovascular related. For simplicity, I put MI or stroke together in one image. So they're holding his heart and holding his head is the MI or stroke. And then you have heart failure hospitalization, or you have death. Okay? And so I have artificially created 4 patients in intervention A and 4 patients in intervention B. And I'm interested in survival, right? So it's time to an event. And if I choose severe things like death, and I ignore the others, non-fatal ones, what do I have? I have that here, this person would be censored here, this person would be censored here, this person is censored here, this person had the event here. So there was one event here, and it occurred fairly early, but there are 3 people that did not. Here I had 2 events. They occurred fairly late, but there's 2 events here versus 1 event here, but these occurred later than that one. So time to event may show that what? This one is worse than that because I'm looking at that. If I'm looking now at heart failure hospitalization, I have 2 and 2. These people are, oh, we had death here. We have a problem here because this person is no longer at risk of being hospitalized because it's dead. We call that a competing risk. For the analysis of heart failure hospitalization, that death is a competing risk because this person is no longer at risk for dying. So this person had a hospitalization here. This is competing risk. And here we have this. So we have 2 deaths and 2 deaths. I mean, 2 hospitalizations and 2 hospitalizations. And ignoring for now the competing risk, these 2 occurred earlier than these 2. So this is worse. So depending on what I choose as the primary outcome, I get a different result. If I choose the composite, then this one occurred, all 3 of these are events. Here we had 3 people with events, but this one occurred earlier. This is later, so these is somewhat in the middle, but this one occurring earlier may say that this group is worse than that group on the composite. There's time to first event of any of the things in the composite. We did the win ratio, now we have to look at which is the hierarchy and so forth and calculate that, but that's not time to event analysis. So the choice of your primary outcome will determine your result. That's very important. The problem is that we have some issues with how we choose the outcome. Most people choose the outcome by what everybody else has done. Everybody that does cardiovascular looks at MACE. Because somebody else has done it. They never ask themselves, why did these people do MACE? They did it to increase power. That's the only reason. And everybody argues that, oh, it makes clinical sense. Of course, it makes clinical sense, but that was not the reason they chose it. So think about it. Choose the outcome properly is one important thing. But as far as survival analysis applied to clinical trials, nothing different from what we talked about in the morning. So alternatives to consider when there are multiple outcomes. You have a single primary outcome, two or more primaries, co-primaries or multiple, composite or win ratio. Is it interpretable? These are yes. This is affected by the dominant component. This is affected if there's ties. If you're comparing two and nobody has died, what do? You have tied data. This is meaningful, interpretable. This is done. Why people do it? Because this is increase in power. This is increased power if event driven. And this is because it's sort of intuitive. Is the effect size understood? Yes, yes. We claim so. This yet has not been understood. Is there software? Yes. This is a little bit crude because it's recently being promoted. Software for analysis? Yes. Methodological caveats? No, this is minimal. There's several and it's many. But all of these are of some utility. You just have to choose which one you want to do for your study, because if done and properly presented, they're all interpretable. But they need to be, of course, properly presented, like everything else in this. But the problem that we have is competing risks. So now we move on from the simple stuff and now get into be complex. So now we don't have time to an event that we can observe. And it's not uninformative censoring. It's being censored informative. That person, that the second one in group A is no longer eligible for having hospitalization for heart failure because they're dead. So death is competing with them. The risk of the event of interest is zero now. You cannot observe. Yes. Right. So that's the problem with, yes, you're totally correct, that if I've chosen heart failure hospitalization as my primary outcome, then everything else is irrelevant. Yes, even if it's missed, it's time to first of those events. So in all of those cases, you don't observe, you don't account for the other ones, you ignore them. And so the problem is exactly that there is information that you would like to capture and you would like to use. So one is the competing, we'll talk about competing events now, but the other one is, if I want to look at all the events that may occur to this person. So people talk about the trajectory or the clinical evolution of the person. First they get a heart attack, then they get hospitalized, they get out, they get treated, now they get a stroke. And now they get a second stroke, and then they finally die. So do we care about that, or we just care about the first? What is, maybe I can delay the occurrence of the first component, but once that happens, everything falls apart. This person progresses quickly and dies. So I want to know how people evolve. Do they just have one thing? Is that the only thing that I care of clinically? No, I care about all of these. And the problem is that all of these events are correlated. The risks of them are not the risks that they had. So my risk of stroke that I had at the start of the study is not the risk of stroke that I have now because I've already had an MI. But now it's changing risks. But all of these things make all these complexities make it hard to know what the hazard, the actual hazard for that cause or the overall survival and so forth. So these are complications that have not totally been dealt with, some of them. It's an active area of research looking at recurrent events. And recurrent events that are the same, like in infectious diseases, people talk about when you study kids and diarrhea, you have multiple diarrheal episodes. And once their kid is treated, they'll say, okay, they go back to their same risk for the next episode of diarrhea because of they've been treated. So that's fine. But that's not the same thing for your cardiovascular system. It's not the same thing for your renal system. It's not the same thing for your GI system, and so forth. Once you've had a metastasis in cancer, it's not the same thing either, right? So those things, those complications make recurrent event analysis much more difficult. And so it's not solved. What we're going to be talking about are things that are actively being worked on by folks. So it's not a cookbook that we can give you on how to deal with it. All right, well, let's look at competing risks. So competing risk happens when the occurrence of one type of event changes the ability to observe the event of interest. So I said my event of interest is MACE. But death from other causes, cardiovascular death is part of MACE. But if I die of cancer, I cannot die of cardiovascular. I cannot have an MI. I cannot have stroke. So dying of cancer is competing with MACE. So it precludes occurrence or alters the probability of occurrence of the event of interest. So then that's given those examples. So, or GI is GI bleeding, death without GI bleeding is a competing risk event. So what do we do? Well, what we tend to do is we calculate the cumulative incidence function, which is the rate of occurrence, is the probability of failure due to a cause K prior to time t. So for each of the causes, I get what's called a cause-specific incidence, cumulative incidence function. So I do the cumulative incidence function for MACE, and I do the cumulative incidence function for non-cardiovascular death. Or if I have multiple, well then here I have for K causes, so I can do it for K causes, and I'll have it for different causes. Most of the time we have 1 or 2 or 3, so K is not usually very big. And the probability of any type of event can be decomposed in the probabilities for each type of event. So surviving or failing in general is now the sum of surviving for any of those different ones. And I can calculate now I get first the overall survival function from the Kaplan-Meier, and I'll do a weighting sum of these of the survival. I'll weight them by those probabilities to get the specific failure distribution for the K type. So what many people do is they just say, oh, I can just use the Kaplan-Meier estimate for this. But the Kaplan-Meier assumes non-informative censoring. And that's where the problem lies. And so if you report the Kaplan-Meier and you had competing risks, which many papers, even in the New England Journal, have, and they don't adjust for it, it gives you a biased estimate of the overall survival. So what we do is, since these are not verified, the complement of the Kaplan-Meier is not an appropriate estimator of the cumulative incidence function in this case. So what we have to do is, was proposed by the statistician in Norway, Alan. And so we have and some of the students, Alan Johansson and what was the other one? I forget the other student. But they propose the following. You can show that 1 minus the Kaplan-Meier is the failure for the K cause can be given from this. Those of you that don't care about the formulas can forget about this. We'll give you the bottom line in a second.
we compare the non-parametric estimator of the cumulative incidence function for the case failure cause. And so we have here that this would be the same, but this is for the kth failure, and this is for overall here. There's no sub k here. And 1 minus Kaplan-Meier will result in upward biases in the estimation of the incidence function if we use that, because we're using not the case specific, we're using this one. So what we end up doing is, whoops. Oh, I don't have it here. Yeah. The Alan Johansson, I thought it was here. Where did it?
Did I not show it here? No. Second. Are these the ones that are not being shown now? Probably have been here. It's there in another one. Oh, and number 2. Or is it coming later? 1 second. No? It somehow did not put it in the slide. You have the Nelson-Allen estimator, the individual ones, and you have the, let's see if I have it here. Maybe I put it in the wrong slide. Sorry about this. Maybe it was at the end. Yeah, so somehow it got here in the wrong set. Okay, well, we'll put it, I'll move it and send it to you guys differently. Okay. Okay. So what we have to use is that we have to use the Allen-Johansson estimator of the cumulative incidence function. The difference is that it's using, for the cause-specific hazard estimates, it's using a different estimate for that. It's called the Nelson-Allen. So it's Nelson is the other student that worked with Allen. So for, let's say we take one of the causes, cause 1. So you do this for each cause. For cause 1, the cumulative cause-specific hazard treats the others as censored. And so you get the cumulative hazard for the cause 1. And it turns out to be this one here, the deaths divided by the exposures time. You can calculate the overall survival, which estimates the probability of survival in any event. That's just the Kaplan-Meier estimator for overall survival. And now you put these together to get the cumulative incidence function for cause 1. Now it's using the Kaplan-Meier one with the cause-specific one. And basically what you get is that the probability of experiences cause 1 at a given time is the probability of surviving up to that time point multiplied by the cause-specific hazard rate of that. So what it's doing essentially is it is using the cause-specific estimate of the hazard to get then the estimate for that each particular cause. And you get cause-specific cumulative incidence functions. This is what is the complication that we have to do when we have competing risks. And reporting cause specific takes more time in the paper. And so many people don't tend to do it. Usually you'll do it if you have maybe one competing risk and you have MACE and death from any other. Okay. You can eventually calculate the cumulative incidence function overall as well. No, you just have to report it, cumulative incidence function for each cause. But you're interested in your primary outcome of MACE, for example. So that becomes cause 1. Cause 2 is the competing risk of death from cancer. So what you're doing is you're still calculating the cumulative incidence function for the cause of interest and report that one after adjusting for the competing risk of the other causes. So you can do it for the causes of interest. Usually you have your primary cause of interest, right? Your primary outcome is your one that you're going to report. So this is what you would be reporting. So you're combining the steps. You take in the Nelson-Allen estimate of the cause-specific hazard, which is the V1, VI1 over YI, and then taking the overall survival. And this is what you end up reporting in this case. If you reported the cumulative incidence from the Kaplan-Meier, you'd be overestimating the incidence and survival. Yep. Right, so you take in everybody in your study. Right? So let's backtrack a little. When we are presenting the Kaplan-Meier, we are presenting the survival curves. We could also present 1 minus the survival curves, which is starting from 0 going up, the incidence. That's the cumulative incidence. But that cumulative incidence is wrong when we have competing risks. It's overinflated. What we have to do is, instead of using the normal way of taking 1 minus the Kaplan-Meier, what we have to do is change it by having the cumulative incidence use a different estimate for the cause-specific hazard, event of interest. That's all we're doing. But then, so now the cumulative incidence that we're reporting is correct. Then you could take, I presume you could take 1 minus that and present that, but mostly you present the cumulative incidence and cause-specific hazards if you want. No, we just say there was a competing risks of cancer death. But you're not interested. You're interested in your primary outcome. You want to adjust for the competing risk. You're not interested. If you could actually calculate the cause-specific cumulative incidence of cancer. But you would not want to report it if your study is not related to that. Competing risk is a nuisance to your research question. We'll fix the slide. I don't know why this was on this slide and not on the other slides. Right. So now comes the other complication. So competing risk is one. The other one is multiple things. Okay, so we've had the simple stuff, one outcome. We've had multiple outcomes. but we see that in composites, and that really doesn't affect the analysis. We have competing risks, which does affect the analysis. So instead of using the Kaplan-Meier curve, we have to use the Allen-Johansson cumulative incidence function. And you'll see that when people acknowledge that in their papers, they'll say we had competing risks. They'll tell you what those endpoints that were competing were. And they'll just simply mention, therefore representing the Allen-Johansson cumulative incidence function. That's it. Software will calculate it for you. You don't have to worry about those formulas, etc. It's not yet, is it in the Shiny app? I think it's in the Shiny app. Yeah, so you'll see it in the Shiny app. But now comes another complication, and this is the more realistic one. That was that example I was showing you, that people have multiple recurrences of things that are related, whether they're the same event, multiple heart attacks, multiple diarrheal episodes, or things that are unrelated. Sorry, not the same, but they are related. So MIs and strokes and hospitalization for heart failure and so forth. So when we have repeated primary outcome, the primary outcome or its components, it really depends on the type of outcome. So we can have repeated continuous outcome, and that's going to be discussed tomorrow as part of joint models. We can have repeated binary outcomes. I'll mention that in a little bit. Or repeated time to event outcomes. We've been talking about time to events. So we'll spend the time on repeated time to event outcomes. But let me mention something of repeated binary outcome, because this is an interesting example that comes from real data that we had. This is not the real data, but it's similar to the real data that we had. So in surgical trials, of importance is once the person is discharged from hospital, the first 30 days are crucial. And there is very much care that's given, instructions to the patient on regimens that they have to follow, to monitor them in case they have any problems, any complications that show up later. They're supposed to take some medication depending on the type of surgery. What tends to happen is people don't follow instructions. All humans say they will, all humans never follow instructions. So people present later on at the emergency department, very expensive, cause disruptions, etc. So one of the physicians was interested in doing interventions that kept people from showing up in the emergency department. And one of those was to have monitoring that's done. One of them was looking at patches that they put on people, but the other one is that every day they checked in, and there was an automated system that registered their blood pressure, registered vital signs, and so forth. They talked to a nurse if something happened, and they were monitored on a daily basis. So that was intervention, and there was a control arm that did not get there. And people were randomized to this, and the idea was, the outcome was days alive and out of hospital in the first 30 days. So this is an interesting one because the data looked sort of like the one on the left here, that in the 30 days, most people were fine. Some people came in for 1 day, some people came in for 2 days, etc. Some people came in for even 10 days. There's 1 minus, or 30 minus there. And so this data looked very strange. But you say days alive and out of hospital, you're counting the days. Oh. So then why don't I use the Poisson distribution? But it should be 1 minus or 30 minus that. And so he did 30 minus that. This is the distribution of days not alive and at home. Okay, so that's fine. We could do the Poisson distribution there. But maybe it's zero inflated because there's not many people that don't come in. There's lots of people at zero. So could we do that? They're not doing time to rehospitalization. So that would have been a time to event outcome.
It was time to rehospitalization. But they chose to do this days alive and out of hospital because that was clinically important, or that was what many people in the perioperative medicine were doing. And so we tried to do that. The problem is that the Poisson distribution doesn't fit the data very well. And so what we ended up doing was we could have changed it to time to hospitalization, but that was not in the protocol. We can't change the primary outcome to it. We still have to analyze this. So what we ended up having to do was the repeated occurrences of the binary outcome. So every day you either were alive and out of hospital, or in hospital, or dead. So dead is a competing risk in some sense because you can't observe, but it included death as part of it. So once you're dead, then you're not alive out of hospital. So then we dealt with that by definition. But now each day we have 30 days, actually 31 days, of day 0 to day 30, measurements of 0, 1. They're all correlated. So we ended up having to do a generalized linear mixed model that was with Poisson for the repeated occurrences. Complications that would have been avoided if you had done time to rehospitalization or death. But we have to deal with whatever people choose. That's repeated binary. That's not the topic of our course, but I just want to give you a real example. What is more common is the following situation. And this is when we have repeated clinical outcomes and we're interested in time to event. So let's say, this is a very busy slide, so I'll go slowly. This is actually from a paper from Ken Modi, who was a graduate from this department at CMC. She's now in Ireland. In Ireland right now. So we take the recurrent event, I don't know what URI is, for 10 infants. It's a urinary upper respiratory illness. Okay, so upper respiratory illness, recurrent events. So this child here was censored at this time point. They were lost to follow-up or something. This child had an infection here, had an infection here. This child had 4 infections. Notice that this one took long in happening. This occurred a little shorter. This had long time for that, but then they occurred frequently. And then they were censored. This one had 6, some of them more delayed, some more frequent. First one occurred fast, then this one takes a long time, and this, and so forth. So different experiences of these 10 children. If you do time to first event, what do you have? You have this one here, 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 here. This is censored. So we have 9 events. And some of them occur early, so they have to look late. If we had randomized intervention, we may have had one result or another. But we lose a lot of the information that's in the other. So what have people proposed? Why don't I use all the information? But what is the statistical problem? The events are within the same child, so therefore they share the characteristics of that child. So therefore they are correlated due to being in the same child. And there are ways to deal with this. So the one way that is very common in the literature is called the Andersen-Gill counting process model. And in the counting process model, we take now, here we only have the top 5 children, childs 1 through 5, and because it gets too busy otherwise. And here's 5 also, and the same 5 here. So the first child had 1, 2, 3. Is it the top one? Oh, which one does she have? There's 1, 2, 3, 4. Oh, and the last one, yeah. The last one. Okay, that's fine. So this first one occurred at 200 and some. So that's the first time that that event was there. And then with you have another event, and that time starts here, 0 to this, and that's that one. Then the next one is a little shorter, and then there the sensor. You have sensor at the end. And and this one here, you can then move them to the beginning for the analysis. This one here, you have, wait a second, this is not right. Because the second one should also be that shorter time period for that other one. I think this one is not correct in this paper. I have to look at that, but you have it up. So the third one goes up to 154, then starts there, and the next one has that one there. The fourth one has this one, and then the other ones are incrementally added to that. I think this one is a copy paste of this one here. Something is wrong there. So they're added to that. So the counting process, once the event occurs, the next event starts 0, and you now look at the time for that event to occur. And it assumes that these are independent. And it models them, but they're not. And so it's not really a good one. The other one is to take the times and now move them, or sorry, take the total time. So for the first one, this to 200 is there. This one occurred at 262, so that's that to 262. The other one at 310, so that occurred to that. And the other one was censored there because they had 4. And this person, they had this one at 84. This one was at 127. So now they take the total time from the start to that. And what Prentice, William, and Peterson said is that I can take all of those different ones and study the hazards of the total time from the baseline of all of those. But more, I think more intuitive to me is Prentice, William, and Peterson also suggested, let me look at those gap times. So now the first one was at that, the next one was this time, so now I move that there, this one is this one, that there, and then I move that. And what they do is they are then fitting a model to these recurrent time to events by adjusting the hazard for each individual for the different recurrences that they have. Okay. Now, what ends up happening is that there is a Cox frailty model for recurrent events that has also been proposed. We're going to be talking more about the Cox frailty model tomorrow, because what you're doing in the frailty conceptually is that we say that in the Cox model, everybody has a common underlying hazard to failure. But in a frailty, we have that each person has the same one for all of their recurrent events. So each recurrent event is now looked at differently. And so we now have the Cox frailty model is one alternative for recurrent events that can be used as well. And so now we have this random effect for person, the ith person, that goes into the model. This is the lambda naught for that event. And this is then the exponential function. But most people that I've seen use the Prentice-Williams-Peterson models nowadays. There's still, as I said, this is an area where statistical methodology is trying to keep up with the needs of investigators to understand better. Are you interested in modeling the gaps between the previous event and the new event? Or are you interested in counting all of those events and adjusting for the fact that you've counted repeated numbers of things in a given person. So we'll have more with that. So we're going to do the competing risk practicum now. Oh, there was another one. Sorry. Yeah. Again? I don't know if there's software for it. I mean, conceptually, yes, you can. You can put in these models, you can put in a random intercept for sight. But whether there must be an R package for it. You know? There must be an R package for it. For the PWP? Yeah, but most likely there is an R package. I haven't looked into it. There is one other way to deal with recurrent events that is presented to you. Not many people use it, but it's people that do Bayesian analysis like to use it. And it is called multi-state models. The concept is the following. People are healthy or at risk. They get some illness. Their risk changes, or now they're a different state. And then they can either progress on to a worse situation and eventually progress on to death or to some terminal event. And so if you have the states that a person is in can be ordered so that you are okay, mild, moderate, severe, death, then you can be modeling what's called in the multi-state model, your transition probabilities. What makes you move from one state to the next? What are the risk factors that precipitate and predict the time to movement to the next state? Or also, what predicts you staying in that state and not progressing? Once you've had when something bad happened to you, what keeps you from having something worse happen to you? So multi-state models are being more recently looked at. And here's an example. So there's a book on this, but suppose you have 4 states: diagnosis, complete response, relapse, or death. And so what you have here in the diagram A is what we call it the transition matrix. So you can, people that are at diagnosis, how many get complete relapse or complete response, how many relapse, how many go directly to death or don't have an event, etc., from different groups. And you have the description of the states and transitions in a multi-state model. And so transition 1, for example, included patients moving from diagnosis to complete remission. Not response, it's complete remission. Why does it say response? This is from maybe I copied it wrong. It's complete response. Transition from diagnosis to death. So some people just die. Transition 3 is from complete remission to relapse. How many transition from complete remission to death, and transition from relapse to death, and the numbers that were in it. Somebody did not get into remission and was lost to follow. So what I like about these multi-state transition models is that you can see once you transition from one, how you remain in that as well. So these are predicted probabilities of being in a specific state over time. So evolution over time of state probabilities from the time of diagnosis to 60 months follow-up. So you have whether you stay in diagnosis or eventually you progress from diagnosis to something else, but the complete remission state is one where you stay for a long time, but once you relapse, you don't stay there long. You move to death, and of course, you cannot move out of death once you move on to it. So this is another way of dealing with multiple recurrent events, is to change the question. You're not studying the time to each event in one way or another, but to studying how long will you stay in your condition. So it's not the event that's important, it's your condition that you're in. Okay? Yes. Good question. So if you are censored, I don't know. If you are censored in this, whether they treat you, yeah.
You mentioned they're not lost to follow-up.
In this study, there were nobody's lost as follow-up. So, but if there is a loss to follow-up, what would they do? So if they're lost to follow-up, you'd end up having to impute their state, right? And say they were in this state and they remained in this state, but that is now overinflating your transition or your remaining probability in that state. I will have to find out what they do. Frank Carroll is a colleague of ours that gave a talk on this. And is the last known state? Yeah, that's you sort of use the last known state. Oh, but the last known, you're imputing the last known carried forward, basically is what you're doing. Last state known carried forward. That's, you're imputing it by saying it's whatever it was at the last one, we keep it. So that's overinflating your probability of remaining in that state. Drop them from this, but then you don't have everybody having the same amount of follow-up. Yeah. Good question. Yeah. Right.
Basically, the probability of the patient to stay in that particular state versus progressing or getting cured with the treatment. So that it is basically calculating the probability, right?
Yeah,
my
no,
question
there's
correct?
two things that you're looking at, the probability of transitioning and probability of remaining.
Yeah. So if the patient is lost to follow-up, still we know where the patient was. We are actually calculating the probability of that patient going to other states, right? So,
but that person could have dropped out because they died.
Basically,
but you don't know.
Yeah, but basically we are calculating based on the available probability with that risk.
So that's fine. And this is the argument that people would make, that I can carry their forward what state they were in for the rest of the duration, but that may be not correct.
Is this the same as Markov model?
Yes, it's coming from a Markov transition model.
I think they used the same.
Yeah, so they do that. That's the assumption.
Yeah,
but it's a good question. If you want to properly deal with censoring, is there a way to do it? Okay, so maybe we go to the exercise. So you're going to have the exercise on competing risk, but multi-state models versus competing risk. The multi-state models describe several events defined by the time to event and the sequential ordered occurrence. So they need to be getting progressively worse, for example. And so you can be used as prediction models for separate health states. And there's that Markovian property that the health states are connected to. So you explain the ordered sequence of the disease trajectories. and accommodate inference or interdependency between health states. But competing risks are useful when you have things like the terminal-like death. It cannot explain treatment effects for the scenarios where non-terminal competing events occur sequentially. So they're often described as a special type of multi-state models where all health states except the initial states are considered to be terminal. Those are the competing events for them. But how they deal with censoring is an important question. All right, so I'll stop here.